my video, no, I'm not in San Francisco. I'm just able to do some cool things with the backdrop on Zoom. So I'm going crazy with that here, having some fun with it. So just some nuts and bolts things. The way these Zoom conferences work, you will not be able to use your audio or your video. Only the panelists can do that. You will be able to ask questions, and we prefer that you not use the chat function, but that you use the Q&A function, which is at the bottom of your screen. So type in your questions on the Q&A, and I will be monitoring that, and we'll save some time at the end to answer questions. So the agenda for, one more thing. If you want to get CME for this, please fill out the evaluation forms and get those in to Lisa, because that's the only way we know you attended. And it's also useful to us to plan future programs to know how people are reacting to the presentations. Next week, I am tentatively planning to do another full grand rounds on COVID again, because I think there'll be some advances in treatments and so on that might be worth sharing. Today, I'm going to do a brief update of the epidemiology and a couple of other things that I've put up here. I have 7 or 8 slides. And then we're going to have a case presentation and discussion. So starting with the numbers here, these are our system metrics. If you look at the upper left-hand bar graph there, it shows you the number of cases in the hospital. So as you can see, over the month of April, the number has been pretty flat. So there've been some discharges and some admissions, but the net effect is pretty flat. These are the discharges in the upper right-hand corner, and these are the deaths down here. So this is from a laboratory standpoint. The system has tested 8,000 samples so far, and about 7,000 of them are negative, 1,000 are positive, and 60 of those 1,000 are employees. As you can see in the bar graph there, the ability to test larger numbers has gone up, and so as you go to the right of that graph, you'll see that they're now testing 400 and 350 patients a day. This is the Monroe County dashboard, which you actually have access to if you go to the Monroe County Health Department website. They update this at 4 p.m. every day. And this is Monroe County residents only. And you see there are 96 hospitalized, 22 in the ICU. This number has actually gone down. It was about 30 a couple of days ago. And 113 confirmed COVID deaths. So it's interesting to look at this. I don't think I've shown this before. These are the various counties in the region, and the number is per 10,000 population. So it corrects a little bit for population density. And so as you can see, Erie County with the blue lines here has the highest number of cases per 10,000 population. And it's still pretty high, about twice as high as Monroe County, which is in the yellow over here, and sort of the second one. Wyoming County doesn't have a large population, but per 10,000 population, it's a hotspot. It's got just as many cases or more than Monroe County. So interesting data why some places are seeing a higher density of cases per population than others. So I was emailed this question yesterday by the hospitalist group, and I sent it to Dr. Lesho. They were asking why, with 6 weeks of social distancing, are we still seeing new COVID cases? Shouldn't they just die out and stop? Are these all healthcare workers? What's going on? And so I thought his answer would be useful to share. So the first point is, you wouldn't expect to see the effect of social distancing for 1.5 to 2 incubation periods. And because the incubation period of this virus can be so long, like 2 weeks, you wouldn't expect to see the effect of social distancing for 3.5 to 4 weeks. So that's one answer. We are 7 weeks into this, though. We are seeing a benefit of distancing, and that's why we didn't turn into a New York City or Northern Italy. And we're talking about restarting elective surgery. So yes, we're seeing an effect, but we are still seeing new infections, probably for those 2 reasons, that there are some people who are not social distancing and there's still some mixing going on. And there are some jobs, healthcare and essential workers, who are still being exposed, and we're never going to be able to entirely stop that. As we reopen, the expectation is that we will see more new cases. So Dr. Cuitas and Dr. Sham and myself, along with Greg Conley, are part of this anticoagulation team that monitors anticoagulation in the hospital. And Dr. Cuitas has been in touch with he's the president of the Hemostasis Thrombosis Society nationally. So he's in touch with the national gurus. And he came up with this algorithm that I wanted to share regarding anticoagulation of patients with COVID. As you know, there's an increased risk of thrombosis in these patients. So everybody should be at least on standard weight-based prophylaxis unless there's a contraindication. But we have tried to sort of simplify this and say that there is a higher risk group, people who wind up in the intensive care unit or people who are on the floor and have a D-dimer level of greater than 1,500. And these high-risk patients should probably get a double dose of prophylaxis, so 0.5 milligrams per kilogram of enoxaparin twice a day instead of once a day, provided their platelet counts are okay and the GFR is okay and so forth. Because the risk of thrombosis really seems extraordinarily high. And then, of course, if there's clinical suspicion for VTE in either of these groups, then consider testing, and if they have a clot, you would fully anticoagulate them. This is another activity that I wanted to share. I know that COVID has sort of created an extra level of stress for providers at various levels, physicians, APPs, nurses. And so a group of our docs who are involved with lifestyle medicine is offering these group sessions at 8 a.m. and 8 p.m. daily. Dr. Natasha Sodhi is the primary facilitator for these, and Dr. Kerry Graff and Dr. James Fenley are also filling in for some of these sessions. So if you're interested in partaking in that, these are Zoom sessions. You don't need to register for them. You just go on, and if you want to participate in the whole thing, it's a 1-hour session with some meditation and some sharing and etc. So I wanted to make people aware that that was available to us. So with that, I'm going to move to the case presentation. Dr. Ogunsesan is going to share her slides now.
Good morning, everyone. Welcome once again to Grand Rounds. Dr. Sham and I would be presenting a hematology case. My name is Yetunde Ogunsesan, and I'm one of the third-year residents. Our topic for today is arsenic and leukemia, new spin on old lace. So to start, we have a case of a 51-year-old Hispanic male who presented to the RGH emergency department with a 3-day history of bruising on both his thighs anteriorly and also on his upper chest. He denied any recent trauma. He hadn't had any rash. He wasn't taking any anticoagulant, aspirin, or any antiplatelet agents. He reported a history of dyspnea and exertion, which started in the week prior to his presentation. On further history, he had a past medical history of chronic foot pain and BPH only. His social history: he worked as a priest. He was formerly a heavy equipment operator. He quit alcohol 18 years ago, and he never smoked. His family history was significant for prostate cancer in his father. His allergies, the only one identified at that time was latex. On review of his systems, it was positive for diaphoresis, malaise, shortness of breath on exertion, heartburn, back pain, and headache. He denied any fever, nausea, or vomiting. Physical exam at presentation revealed vital signs with blood pressure of 143/83. His temperature was 36.7, and he was saturating 99% in room air. He was awake, laying comfortably in bed with no acute distress. Further physical exam showed he had a left submandibular lymphadenopathy. He had good air entry bilaterally. Heart sounds were S1 and S2 only without any murmurs. His abdomen was soft with a mild tenderness in the left lower quadrant, and he was noted to have significant bruising over his thighs anteriorly. He had no edema or no rashes. Lab work was then done for him. As we see, his complete blood count showed a normal white count of 6,900. He was anemic with hemoglobin of 11.6 and hematocrit 32. His platelets were, however, significantly low, as he had only 11,000 platelets, thus he was thrombocytopenic. Differentials on his complete blood count showed his neutrophils were 2, lymphocytes 1.9. He had no bands, no blast. 37 of the cells were, however, reported as unidentified cells. Further lab work showed his PT was 12.7, INR 1.1, his fibrinogen was 90, and his fibrin split products were elevated at greater than 20. LDH was 456, and aptoglobin 45. Further lab work, his basic metabolic panel showed the sodium of 141, potassium 3.9, and creatinine 0.8. His albumin was 4.2, AST and ALT were essentially within the range of normal. Following this, he had a peripheral blood smear done. And on this slide, I'll just highlight in this lower corner, we have this cell with the bilobe nuclei and the cytoplasmic granules, which is quite characteristic of a promyelocyte. And in the other side, on this other side, we have this couple of cells which we can describe as blasts. And then his hospital course started. On the first day of admission for his thrombocytopenia, he was transfused platelets. He developed a transfusion reaction, which was, however, successfully managed with Benadryl. On the second day, he had a bone marrow biopsy done and also had cryoprecipitates transfused. The bone marrow aspirate is as shown on this slide, and I'll just go through some of the findings on the slide. Here again, we have this cell with a prominent bilobed nuclei and AZ cytoplasmic granules, which is particularly characteristic of promyelocytes and what we would term the microgranular variant. In the lower border of the cell, of the slide, however, we have another cell with a very prominent nuclei and more tightly packed dense plasmic granules, which is also another variant of promyelocyte. The bone marrow biopsy was very hypercellular, was read as 100% cellularity. For his age, we expect the cellularity to be at about 50% of his bone marrow. And here, I'll just highlight, we have this island, as it is in other parts of the slide, of very immature cells with prominent nuclei. The pathology report was as follows. Bone marrow aspirate was aspicular but cellular, and a 200 cell count demonstrated 75% neoplastic appearing promyelocyte, a subset of which were bilobed with fine chromatin, fine to occasionally coarse cytoplasmic granules, and variable nucleoli, favoring the microgranular variant of APL. The biopsy was also said to be hypercellular, and the marrow cells predominantly neoplastic promyelocytes with immature nuclei. The cells were positive for translocation 1517, which is characteristic of acute promyelocytic leukemia, FLIC3 positive, and NPM1 negative. Based on this, it was said to be like based on the histologic, immunophenotypic, cytogenetic, and cytologic findings are consistent with acute promyelocytic leukemia. Back to his hospital course. On the second day following the preliminary findings from his bone marrow biopsy, he was started on tretinoin for treatment of APL. By day 4, we had our final results, and he was then started on arsenic trioxide in addition to the tretinoin. Prednisone was started at 0.5 milligram kg per day for differentiation prophylaxis, as we expect with response to therapy, the white cells will start to mature and differentiate. Days 5 to 9, he would notice an increase in his white cell count as expected with treatment. By day 9, he was started on hydroxyurea at 500 milligram BID, and the dose was escalated as the white cell count continued to increase. By day 10, he started him on allopurinol for tumor lysis syndrome. However, the following day, he developed a papillary rash, was diagnosed with a drug reaction, and the medication was discontinued. By day 12, his white cell count had risen to 100,000. Of note, at presentation, his white count was 6,900. This made us to give him idarubicin, which is a topoisomerase inhibitor for hyperviscosity syndrome prophylaxis based on the leukocytosis. He developed fever and tachycardia, and we had to start him on IV antibiotics during the course of the admission. And then also he developed a vesicular rash in the pubic region. He was diagnosed with a reactivation of genital herpes and was started on IV acyclovir. By day 16, his white cell count had gone down to 11,000 from 100,000 on day 12. The hydroxyurea was discontinued and a prednisone taper was started. Over the course of days 1 to 25, he was transfused platelets and cryoprecipitates as needed. By day 26, it was noted to have an increase in his platelet count without a need for further transfusions. On day 35, a repeat bone marrow biopsy was done. The aspirate from the repeat bone marrow biopsy is as shown in this slide. And here, basically, what we see is we're starting to see maturation and hematopoiesis in all the 3 lineages. In this corner, we have a maturing group of myeloid cells. And right in the middle of the slide, we have a megakaryocyte. And here, we have a group of nucleated red cells, which showed erythroid maturation as well. The bone marrow biopsy, the core biopsy itself, still showed a hypercellular marrow, but it was not as cellular as it was prior to treatment. And again, here, we can see there was some form of trilineage hematopoiesis, as seen here with the megakaryocytes. We have here an island of myeloid cells and some nucleated red cells in this field. The report was read as a hypercellular marrow with tri-lineage hematopoiesis, mild increase in blast count, no definite increase in poor myelocytes noted by morphology. Cells were FLT3 negative and positive for translocation 1517. On day 37, our patient was discharged home and is following up with the hematology oncology unit as outpatient for his consolidation therapy. And I'll hand over to Dr. Sham for the rest of the presentation.
Good morning. This is an unusual way to do grand rounds. Having done probably 20 of them over the years, I've never done it remotely. So hopefully people can hear me and have some questions at the end, but I'd like to give an overview of acute promyelocytic leukemia. And I always like to start with a little bit of history. Leukemia was first really described in the mid-1800s in Europe. And by the late 1800s, the acute leukemia was really considered a separate entity from chronic leukemia. In the early 1900s, there were developments in chemistry that led to histochemistry and classification schemes for many pathologic disorders. In the early 1940s, there was the early work with folate antagonists and nitrogen mustard, which subsequently led to some of the chemotherapy developments. And in terms of history, I had actually given grand rounds on this. I don't know if people can see this. This is from 1992 with an overhead projection and Kodachromes here. So this is a more modern way to give the talk. So in 1960, Nolan Hungerford at the University of Pennsylvania described the first chromosomal abnormality consistently associated with a neoplasm. That's the Philadelphia chromosome with CML. In the 1970s, Janet Rowley at University of Chicago showed a number of the changes in leukemic cells were translocations and not deletions. Later in the 70s, B and T cell markers were being discovered, and then subsequently myeloid markers. And it wasn't really until the 1990s that what I would consider the early wave of molecular markers were developed for neoplastic diseases. So that's really not that long ago. It was just a few years before we had a talk on this in the past. So it was around 1950 in France where APL was described as a subtype of AML, and it was known for its exaggerated hemorrhagic complications. And then it's felt to represent about 10% of all AML cases. And then the points below are some of the key clinical characteristics. The coagulopathy is very important. It's controversial how it's best managed, but clearly one needs to keep track of the fibrinogen. The morphology is often very characteristic with prominent granules and hour rods, and very notably, these patients often have a low white blood count. Often students and residents are surprised because they think that acute leukemia has a high white count. These patients often present with a very low white count. They have the cytogeneric finding of the T1517 as our patient did, or sometimes a molecular equivalent. And it's very helpful to see that. And in fact, if you don't see that, you need to question the diagnosis. The treatment, even before some of the modern therapies, was associated with a absence of complete aplasia often and evidence of maturation. And most of what I'll be talking about is the use of all-trans retinoic acid, or ATRA, and arsenic trioxide. So just a couple words about cancer cells in general. Their normal growth pattern is altered, and frequently the cell is arrested in a more primitive stage and unable to regulate its maturation. In the 1970s, it was first recognized that the environment that the cells live in has some impact. And early studies with leukemic cells showed that you could differentiate them in the appropriate environment. This kind of work began in the 70s and 80s with retinoic acid showing to have anti-tumor activity in cancers in mice. And at the NIH, there were studies done that showed retinoids could induce differentiation and inhibit clonal growth of HL60 cells. Now, HL60 cells are a cell line from a leukemia patient that mimic APL cells, although they're not derived from APL cells, and they've often been used as a model for studying this disease. So the clinical presentation, often leukopenia, as I mentioned before, and the risk stratification for high risk and low risk is based on the white count. The typical blasts are not always seen in the blood, as in this case, they describe unidentified cells. So I want to point out to any students or residents, you can't ignore a lab report that says an unidentified cell. Often these are read at night by a lab tech, and the following day, one of the pathologists may review it and subsequently change the reading and say it's a blast, it looks like an early promyelocyte. Thrombocytopenia is common and often severe, often more severe than in other forms of acute leukemia. And the coagulopathy is extremely common. In fact, the low fibrinogen is really one of the hallmarks of the disease. All cases of acute leukemia can have a very high mortality, but APL can be fatal fairly acutely due to intracranial hemorrhage. That's particularly if it's not recognized and treated quickly. And as a result, we have a different threshold for concern for platelets. And a lot of patients with APL, when we're managing them, we attempt to keep their platelet count at a higher level than we do with other patients with acute leukemia, in part because they have a more complex coagulopathy. And the demographics for regular AML, the average age, mean age is between 65 and 68. And in APL, it tends to be younger and possibly a higher percentage of individuals of Hispanic origin. And here's some pictures where you can see, on this side, you can see the hour rods here. And here are all the granules, and not all of them are classic blasts. These are immature promyelocytes. And here's a nucleolus you can see in this cell. So these cells with multiple hour rods are called faggot cells, from the Italian here, which stands for group bundle. It was originated in Imperial Rome, and it's the symbol of power over life and death. Here's the symbol, and we even had it on some coins in the United States. Actually, this symbol was popular with Mussolini, so it's been around for a long time, and even before that. Now, on the karyotype here, you see here's chromosome 15 and 17, and there's a translocation where there's a rearrangement of genetic material. On the molecular level, you have the PML gene connected to the RAR alpha gene. And that results in a gene product, which is a protein that alters differentiation. And here's a little picture of the two genes rearranged. Now I want to turn now to some history about retinoic acid. As I mentioned earlier, HL60 cells were originally used to study leukemic cell differentiation. And in the late 70s and early 80s, there were studies with retinoids, even cis-retinoic acid, to see how HL60 cells matured in vitro. Cis-retinoic acid did have some use in oral leukoplakia, mycosis fungoides, and MDS, but not with great success. But one of the pivotal case reports was in 1983 from University of Minnesota. This was published in Blood, where they had one patient who was given cis-retinoic acid, which is really Accutane, and he had in vitro and in vivo maturation of his APL cells. Subsequently, in the mid-80s in Shanghai, there were studies being done with trans-retinoic acid. And this is really one of the most important discoveries from my perspective in the last 30 or 40 years in hematology. And there were three main papers that I want to mention. The first one was 1988. This was published in the journal Blood, and it was from Shanghai, where 23 of 24 patients, most of whom had been previously treated and had relapsed, responded to all trans-retinoic acid with less morbidity and no DIC seen. Now, this paper is kind of near and dear to my heart because I presented this when I was a hematology fellow in 1988 to a group of very well-regarded hematologists, and they, quite frankly, didn't believe me. They said, there's no way that you can take these patients and give them this vitamin A analog and they're going to go in remission. And they pretty much said, Ron, why are you presenting this crap at Journal Club? And only to be shown that within a couple years, the group in Paris who had worked with the group from China published the same thing. That was on the cover of Blood, so that was actually a big deal. And 14 of their 22 patients responded. And subsequently, a clinical investigator from Sloan Kettering, who had been in Paris, came back to New York and published in the New England Journal about patients responding to ATRA. And this became major news. And within 1 or 2 years from this, the American Society of Hematology was really swamped with articles about all-trans retinoic acid and APL. But interestingly, the molecular features of this disease were not that well worked out in the 80s. It was only in the early 90s when this whole issue with the retinoic acid receptor was more defined. So when we talk about maturation of a cell in vivo, here is a cell that looks almost like a neutrophil, but it still has hour rods. So this highlights how this cell is derived from the malignant clone. And what is felt to be happening is you have both malignant clone that is maturing in vivo, and you have your healthy clones, which, if you eradicate the leukemia, will repopulate the marrow and allow you to achieve remission, which is ultimately what happens. Now, the adverse effects of ATRA include a headache and a pseudotumor cerebri, skin and mucosal dryness, bone and musculoskeletal pain, some changes in liver enzymes and triglycerides. It is a teratogenic drug. We did have we had to use the drug in special permission through the ethics committee and some other committees. She had a baby that unfortunately was not viable, but it is a very dangerous drug in the setting of pregnancy. Many patients, as our patient, get leukocytosis as the leukemic cells differentiate. And sometimes the white count can go from, say, 0.8 up to 100,000 in a matter of a week or two. And that can be quite dangerous. And the most notable finding, which had never been described before in any scenario, was what we call retinoic acid syndrome. And now we refer to it as the differentiation syndrome, where the patients get fever, respiratory distress, pleural and pericardial effusions, lung infiltrates, heart failure. And this responds quite well to dexamethasone. And this is not really a capillary leak syndrome. It is felt to be the cells which are maturing in vivo rather, interacting with other organs that they're not usually exposed to. So it's a very unique syndrome. And it only happens when the drug is working. So if you give retinoic acid to another type of patient with leukemia, first of all, it really helps and it doesn't cause this syndrome. So it's very characteristic of a response. So it's kind of a good news, bad news thing. It means it's working. So ATRA was used in the early 1990s in the United States, and then we started adding chemotherapy drugs, initially hydroxyurea, and then we started adding other drugs with agents such as idarubicin, it was mentioned, or daunorubicin. And for the subsequent next 15 or 20 years, there were multiple studies using ATRA with different chemotherapy combinations, and then a lot of debate about how much maintenance chemotherapy was done. And if you look in the literature from the 90s and the 2000 to really recently, you'll see there's a lot of debate about the timing of chemotherapy, which agent is used, which class of agents. But more recently, the interest has turned to arsenic in combination with ATRA. So arsenic has been around for a long time. Here's a description from the early 1930s, and notably here for Hodgkin's disease, it says arsenic should be pushed to the farthest limit short of toxic effect. So this is probably what we consider now the maximum tolerated dose, but here it was used for a number of other disorders. For the chemistry majors in the group, it's number 33 on the periodic table, and it has been used and misused for many different disorders throughout history. In the 1700s, it was in a solution called Fowler's solution for psoriasis. It was used for syphilis in the early 1900s. There are reports of it being used for chronic myeloid leukemia in the mid 20th century. And it has been used as a folk remedy in China for many years. And there's really epidemiologic studies that showed that it had a subset of patients who seemed to get better with arsenic when they had acute promyelocytic leukemia. And in 1998, the same group at Sloan Kettering published the original trial of the first 12 patients who got arsenic trioxide for relapsed acute promyelocytic leukemia. And we have a nice connection here in Rochester because patient number 11 here, this 28-year-old gentleman, was one of our patients here, treated on 5,500. And patient number 9 was a young boy from Webster, New York, who subsequently had a bone marrow transplant. He's still alive and well and does fundraising every year in the community with something called Christopher's Challenge. So any of our people from Webster may know this family. So arsenic was originally used for relapsed disease, which is often the case with many new agents. You use it in desperate situations, and then if it works, you move it further up into the treatment plan, and now it is used in many frontline settings. Many countries have studied arsenic, United States, China, France, and Spain, and the publications for this have actually been very international, which is quite interesting to see, because when I started in hematology, most of the studies that were presented at meetings were from the United States, and there's a lot of nice collaboration internationally, as there should be. So now there have been a number of clinical trials using ATRA with some of the chemotherapy agents with a very high cure rate, maintenance regimens, initially for 2 years, more recently for 1 year, also with a high cure rate. And now arsenic has been introduced frontline, and we have what are considered chemotherapy-free regimens, where all transretinoic acid or ATRA is used, and then arsenic is introduced. In the patient we described today, they did get idarubicin because they did have a very marked increase in the white count, as often seen when they undergo maturation. And we needed to actually calm down the leukemic burden. But in some cases, if they do not get that rapid increase in the white count, they can be treated just with ATRA and arsenic. And here is a little cartoon showing what happens with ATRA really being an agent that focuses on differentiation. And arsenic has both impacts on differentiation and programmed cell death, the apoptosis pathways. And this is still not 100% fully understood, certainly not by me, but I think even basic scientists that study this. But this has now become the standard of care for APL to use ATRA and arsenic trioxide. And now for what happened with our patient's clinical course. The diagnosis was established, received induction therapy with the ATRA and arsenic. There was a lot of supportive therapy used with platelet and red cell support, and then hydroxyurea, prednisone for the retinoic acid syndrome or the differentiation syndrome, and then idarubicin. And then a repeat bone marrow showed a complete remission. And then the consolidation therapy is using a combination of arsenic and ATRA, and that's being done as an outpatient. Now, interestingly, the patient I mentioned earlier that we treated here in Rochester, he was the first person in Rochester to receive arsenic. And it was about a year before we had cancer center pharmacists that worked with us. And it was quite an interesting phenomenon to see the pharmacy here at RGH preparing arsenic and administering arsenic to a patient on 5,500. Because he went to Sloan Kettering for his first treatment. But the investigators at Sloan Kettering fortunately trusted us enough here at RGH. They let us give subsequent treatments here. It was quite an interesting experience. So I just want to end with a note here that June 24th, 1984 was when I started my internship. And I actually, the very first day, I admitted an 18-year-old young woman from Painted Post, New York with APL. And we really had very limited knowledge about how to manage her back then. And she actually did well for about 6 months and unfortunately died. And it's very dramatic to see how the advances have come over the last 35 years. And again, this is an unusual way to do grand rounds. The one benefit I can see, I'll embarrass her, but my daughter, who's graduating medical school in 2 weeks and will be starting her internship, is listening somewhere in Washington, D.C. So I'm going to end here and take questions if there are any questions.
All right. I'm not seeing any open questions. I did get a couple of questions about the COVID presentation. So I can take a minute to talk about something related to that, and we can wait and see if people post questions about APL in the meantime. So someone asked, why are we seeing healthcare workers get infected? Aren't they using appropriate PPE? And the answer is, indeed, they're using appropriate PPE, and they actually might be at more risk getting infected from asymptomatic carriers, either patients or their own colleagues. So I want to make people aware of a case of nosocomial transmission that did happen in the hospital over the past week, because I think it's instructional and educational. So there was a patient on one of the medical floors, an older gentleman with some dementia who was wandering around a little bit outside his room, going up to the nurse's station, asking questions and socializing. And he had been in the hospital for at least 6 weeks. He developed COVID over the past week. So he's not been anywhere else for 6 weeks. So this has to be nosocomial. He caught it from one of the staff, presumably. And because this happened, we did a lot of testing on this floor around this patient's room, patients, staff, everybody. And it turned out that 7 patients on this floor, all clustered around this single patient's room, were all positive for COVID. And 11 staff members were also positive for COVID, 8 of them nurses. So this has sort of resensitized everyone to the issue of asymptomatic carriers. All of these people were asymptomatic when they were tested. So presumably the infection had just occurred. But some of them have subsequently developed some symptoms. It's still early in the course, so we don't know if anyone's going to get really sick. Dr. Jackson asked me if I'm in San Francisco, and so the answer is no. I'm just playing around with Zoom backdrops.
Is Dr. Jackson still on?
Can't go anywhere.
If Dr. Jackson's still on, that was his patient, our first patient that we presented in 1992. Yeah. So it's fitting that he's here listening, because that was he was very involved with that family. So we appreciate his help.
And then someone says that that nosocomial transmission is horrifying, and indeed that's true. Dr. Jackson sends me a name of a patient, which I'm not going to share for privacy reasons. And then Dr. Stern says, what is appropriate PPE? Other countries seem to be using more elaborate gear resembling a spacesuit. Are these available in the US? And is there any evidence that they are more protective? So I don't have one of the infection control guys on the panel today, but let me get an official answer to that next week. The thought is that if you wear an appropriate mask, and you don't even need an N95 as long as you're not in a room where there's aerosolization going on, that if you're wearing a mask and if you take touch precautions, so you're either wearing gloves and you take them off, or if you wash your hands meticulously before and after, you should not get infected. I mean, people are also gowning up and doing the full donning and doffing, but no, it's not spacesuit gear. They're wearing masks, face shields, and appropriate gowns. All right. See if there's any more. There's an attendee that says it's hard to believe our current measures are adequate if there are cases among us. Yeah, I think the big issue is asymptomatic carriers. And so I think the universal masking and treating everyone, including your colleagues, like they might potentially be shedding virus, I think that's where people are at highest risk, not with the patients that we know have it and will take all the precautions going into the room. I think that's almost less risk. Dr. Zenitz says, I see colleagues and staff eating together at the hospital. Is there policy or way to enforce masking? I agree this is more risk than not having spacesuit gear. Yeah, I guess that's more of a comment than a question, but this would be a question of our infection control folks. How much socializing among staff should we be limiting? Any updates on antibody testing? I'll bring that back to you next week. I know Dr. Walsh is doing a study looking for IgA antibody in nasal secretions and IgG in serum in 100 COVID patients after recovery and in 200 community controls. But that's going to take several weeks. And general antibody testing is not available at this point. Dr. Jackson says the technical transmission is great. Yes, I agree. Any specific things that non-hematologists should look out for in patients with arsenic being treated for their leukemia, Dr. Sham?
I think it's so highly regulated, and we probably have in a community like this only a handful of patients a year, that I doubt it's going to be the type of thing that one of the internal medicine or primary care folks are going to need to be too worried about. But there are some toxicities that we keep track of. There's QT prolongation, and there's some actual clinical side effects that they can feel poorly, GI side effects, a number of other things. The main thing we worry about is the cardiac rhythm issue. So we maintain a close watch of their rhythm strips. In the cases I've been involved in, that's pretty much checked every week. And if they're on medicines that impact the QT interval, that's something we would have to keep track of as well.
Dr. Jadhav asks, are we using remdesivir in our hospital? I think we have on a compassionate use basis in a couple of patients. There's also the trial at the U of R that we're able to put our patients on, but that's placebo-controlled, remdesivir versus placebo. I think remdesivir may be on a fast track to getting approved, so this may be a moving target, might change quickly. And then I think the comment from Dr. Cuides is open to see to everybody because it's in the chat rather than the Q&A, so I'll let you look at that. Yes, social distancing is really, really important, even among the staff, but it's really, really hard to do when you've got a team of close people. So, okay, I think we went through all the questions and our time is just about done. So we had about 170 participants to start and about 15 dropped off when the COVID portion finished. So we had about 150, 155 that then dropped to 130 by the end of the presentation. I don't think it has anything to do with the quality of the presentation. I think people are just busy and catch parts of this if they can. And again, I think the number we see possibly underrepresents what is actually happening because some people are sharing screens. Please share screens with social distancing if you're doing that. And with that, I guess I will end the grand rounds. Next week, we will have a formal COVID update, which I'm planning to include epidemiology, treatment, and I'll see what else the demand is for. Perhaps Dr. Cuides can do a little blurb on thrombosis and thrombosis risk and prevention. So if you have thoughts about aspects of the disease that you would like to see presented, send me an email and we'll be getting the speakers together and putting this together by this weekend. So thank you very much, mostly to our panelists and to everybody who participated. I will end the meeting at this point. Thank you.